Gloria, I'm going to try sharing my screen.
Alyssa, are you able to give her screen sharing privileges? Perfect.
Speakers.
Okay.
Why aren't my speakers working here?
Can you see my screen?
Yes.
Okay, great.
Ellen.
Thanks. And okay, thank you.
So we'll give this just another minute.
And then Lori, if people will put questions in the chat, if I don't get to their questions, can you or Alyssa monitor the chat?
Yep, you bet.
Great, thanks so much.
Ellen, do you know if Tim is going to join for the entire presentation? Should we wait until he joins us?
No, I believe he has a prior engagement until at least 11.
Oh, okay.
So I expect him after that.
After that time. Okay, perfect.
Yeah.
We have one more minute. We have about 40, just slightly north of 40 registered, and we've got 38 on today. So there may be people who are joining us. They'll be trickling in. I have 10 o'clock, Ellen. So why don't we get going? I want to welcome everyone to what has become an annual presentation from our colleagues at the Healthcare Authority. Ellen Wolfhagen has prepared a very detailed presentation. And what we're going to ask is if you could put your questions in chat, and Alyssa and I will be monitoring the chat. Ellen's always really great about stopping and asking for questions, and that's probably going to be the easiest way for us to manage your questions because of the number of people that are on today's webinar. Before I turn the presentation to Ellen to give more of a self-introduction, I want to remember to do this. I want us to all take a minute and offer our appreciation to Ellen for what she has done over the last number of years to keep us well informed. She's been a wonderful partner, and she's finally going to get a chance to retire. And she'll be eligible to join RPEC. And so we just want to thank her for her service to the state and for the work that she's done with RPEC in particular. So Ellen, thank you for all that you've done with us and for us. And so I'm going to offer my appreciation, and you can clap. If you don't know how to use you can go to reactions, and there are ways that you can clap your hands, or you can do other kinds of expressions. But I just wanted to remember to say thank you.
Yay, Ellen, thank you.
Thank you so much. It's very nice, Lori.
So with that, Ellen.
Okay, well, I am the retiree benefits manager, and as Lori said, I will be retiring at the end of the year. So my interest in this subject, the Medicare portfolio for PEB, it's very near and dear to my heart because obviously I will be somebody taking advantage of these options as well. Today we're going to talk about PEB and Medicare generally, the Medicare retiree options, changes for 2025. We'll talk a little bit about non-Medicare retirees and changes in that area. And then I have a list of resources and of course, questions and answers. And as Lori said, there'll be time at the end, certainly, for more questions. But if people have questions in the middle and you need to interrupt, that's great. I'd rather that the questions go with the topic as we're talking about them. So PEB and Medicare generally, you have to be in Medicare Part A and Medicare Part B to enroll in a PEB plan. You pay your Part B premium directly to Medicare, and that's in addition to what you pay to HCA as a premium. And there are different Medicare plan types, and each works slightly different with Medicare. And again, Medicare Part A covers inpatient services. Medicare Part B covers outpatient services generally, also some infusions, durable medical equipment. And then Medicare Part D, like dog, is the prescription drug coverage, and we'll talk about that in a lot of detail coming up. So the types of plans that we have, and I just want to say these slides are available. Lori will make sure that everybody gets a copy of the presentation, and the meeting's also being recorded. So if you miss something, please be assured that you can go back and look at the slides and you'll get the information.
Ellen, we also put them in chat so people can click on that and they can save it to their computers. And yes, we will
Excellent.
have a landing page that'll have Ellen's presentation, both the recorded version and her PowerPoint.
Excellent. Thank you. So coordination of benefits is the kind of insurance where Medicare pays primary for medical claims. It's Medicare as a fee-for-service basis. So there's a schedule that the Center for Medicaid and Medicare Services puts out and says, you know, this is how much we'll pay, for example, for a primary care doctor's visit. There's no cross coordination of your care because each provider that you see is separate and doesn't necessarily coordinate with any other provider. Medicare Advantage is a different way of operating. So for Medicare Advantage, CMS, the Center for Medicaid and Medicare Services, gives money directly to the carrier, the insurance company. And then the insurance company is responsible for coordinating all the care and determining what care is given, where, when, and in the most appropriate way. All of the Medicare Advantage plans in the PEB portfolio are employer group waiver plans. That means they're very, very different from anything on the commercial market. The employer group is PEB, and PEB has not only all the state agency employees and higher education employees, but we also have employer groups that buy into us. So we have a very large market basket, and we can use that to negotiate the best coverage, the lowest costs, and the most comprehensive plans possible. So that's very different than the commercial market where people are individuals and have an individual relationship with the carrier. Medicare Advantage plans can be HMOs, that's a health maintenance organization, which has a closed network, or they can be PPO, which is preferred provider organization, which means you can choose any provider that's in their network. And in some cases, you can choose providers outside the network. And there's more flexibility with a PPO plan. Medicare Advantage plans can include Part D prescription coverage. Sometimes those are referred to as MAPDs. Going forward in 2025, all the Medicare Advantage plans within the PEBB portfolio will be MAPDs. They will all include Part D prescription drug coverage. Medicare supplement plans are sometimes called Medigap plans. That's Plan F or Plan G. These are designed just to cover the 20% copay that Medicare does not cover. So Medicare itself pays 80% of inpatient charges under Part A, or 80% of outpatient services under Part B. And the Medicare supplement plans pay the other 20%. Medicare supplement plans do not cover anything that Medicare does not cover. For example, gym membership, hearing aids, routine vision care, hardware, vision hardware like glasses or contact lenses. And these plans offer no drug coverage at all. So if you are on one of these plans, you have to go to the commercial market to purchase a standalone Part D plan. The coordination of benefits plan that we have is UMP Classic. It is now called UMP Classic Medicare with Part D PDP. So you will see this very long phrase over and over again during open enrollment. This is the UMP Classic Medicare plan. There is only this plan with the embedded Part D prescription drug coverage. There is no alternative prescription drug coverage available with UMP. For Medicare Advantage, we have Kaiser Northwest Senior Advantage with Part D, Kaiser Washington Medicare Advantage with Part D, and the United plans PEBB Complete and PEBB Balance, which have been known for a few years as MAPD plans. All of the Medicare Advantage plans, as I said, include Part D and can be referred to as MAPD. The Medicare supplement plans are Plan F, which is closed for new enrollments, and Plan G. If you are on Plan F and have a change in circumstance that causes you to terminate that coverage for a while, when you come back, you would pick up Plan G. The coverage is exactly the same with one minor difference. Plan F pays the Part B, like boy, deductible. Plan G, the member has to pay the Part B deductible, but with the premium savings for Plan G, which costs less than Plan F, that should cover the Part B deductible. So you can think of Plan F and Plan G as pretty much interchangeable. The coverage is the same. The benefits are the same. There are differences in how the plans work. Coordination of benefits, which is the UMP Classic Medicare plan, it acts as full secondary insurance to Medicare. So Medicare pays first, and then you have this secondary insurance that would pay anything that Medicare doesn't cover, and is very, very flexible and can backfill some of the things that Medicare does cover. The UMP Classic Medicare plan covers Non-emergencies internationally. It is important to know that all Medicare plans cover emergency services internationally. But only some plans cover non-emergency services internationally, and that would include UMP Classic Medicare. It now includes Part D coverage. We're going to go over what that means in great detail coming up. And you have to live in the United States to take advantage of this plan. It used to be that there were people who lived outside of the United States who were on UMP Classic Medicare because instead of using their Medicare side of it, they were using the UMP side of it. But now that the prescription drug coverage is a Part D plan, you must live in the United States to have a Part D plan. So people who are on international coverage can have their PEBB eligibility deferred, and they can come back when they return to the United States and return to Medicare. You cannot use Medicare services outside of the United States and its territories. The Kaiser Medicare Advantage plans are both HMO plans. So again, an HMO is a health maintenance organization, and that means usually a closed network, which means you have to see their network providers. There are some very limited exceptions for out-of-network services if Kaiser doesn't have a direct relationship for a certain service. These plans are regional. You must live in the service area for the plan. So you have to be careful about that. And they have limited coverage in different areas outside their service area. So it's also important to recognize that. Again, the Kaiser plans will now include Part D coverage. And it's important to know that the reason that UMP picked up Part D is the same as why Kaiser moved to Part D plans, and we'll talk about that in a second. The United plans, which are PEBB Complete and PEBB Balance, these are group Medicare Advantage PPO plans. And that's a phrase that's very important. It's important because a group plan, as I said earlier, is different than an individual Medicare Advantage plan. And a PPO plan has the broadest available provider list. And it's important if you're talking to providers that they understand that this is a very flexible plan that allows for different providers. So it's a group Medicare Advantage PPO plan. You can see any provider who accepts Medicare, and this is true for any Medicare plan. If your provider does not accept Medicare, the claim will be denied. So you always have to see a provider who accepts Medicare. There are providers now who are opting out of Medicare, so it's important to check. There is no difference in these plans in the copay between seeing somebody in network or somebody out of network. There could be differences in the reimbursement if they're out of network, and that would be Medicare covered services for which the provider did not bill United directly. So you're seeing an out of network provider for Medicare covered services. The reimbursement is limited to the Medicare allowed amount, less a copay if there is any copay. For non-Medicare covered services, for example, massage therapy or acupuncture, those things are not Medicare covered. Reimbursement is 100% of the billed amount, less any copay if there is one. These plans are nationwide, and these plans also provide coverage for non-emergencies internationally. Remember that Medicare itself covers emergency services internationally, but only UMP Classic Medicare or the United plans cover non-emergency services internationally. These plans also include Part D pharmacy coverage. Medicare supplement plans, Plan F is closed to enrollment, as I said, so Plan G is open. As I said, they're designed to cover the 20% that Medicare does not cover. The Part B deductible has to be paid by the member under Plan G. For 2024, it was $240. It has not yet been set for 2025, but it will be in that range. They're nationwide. They cover emergency services only internationally. And there is no drug coverage. Again, if you have one of these plans, you have to get a Part D standalone plan under the commercial market. That would be an individual Part D plan. That's outside of PEBB. Premera itself, while these benefits are not part of the plan, it does offer discounts for gym membership, hearing aids, and more. And those discounts are available to anybody who has Premera insurance coverage. So it's not a direct benefit of the plan, but if you are on the plan, you can get these discounts through Premera. So again, Part D, the switch was made from UMP Classic Medicare with creditable drug coverage to Part D coverage. And as I said, the reason for this is the same reason that Kaiser switched their plans from creditable drug coverage to Part D coverage. Creditable drug coverage is at least as cost effective as Part D, but it does not take advantage of subsidies that come from the federal government. Those subsidies pay up to 75% of the drug costs. So it reduces the cost for premiums and reduces the cost for the plan itself, for the carrier. All of these plans are taking advantage of these subsidies, but it's important to note that the Part D plan in UMP is a little bit different than the Part D plan in Kaiser, which is a little bit different than the Part D plan in United, which is a little bit different than an individual Part D plan. So in the portfolio, we have employer group Part D plans. These are specifically negotiated by HCA. So we have more coverage, better benefits. We have, for example, a bonus drug list, more drugs covered. We have lower copays. We can provide some over-the-counter coverage. Things like that would not be available in the commercial market on individual Part D plans. But the actual drug list depends on the carrier and how they classify those drugs. And so the Part D plans are different within each carrier plan that we have. For UMP, MODA will still be the pharmacy benefit administrator. So you will have virtually the same experience that you currently have with UMP. Washington Prescription Services, which is a term that you may be familiar with, is changing its name to Array RX. So you will see Array RX instead of Washington Prescription Services, which I think is also known as WSPS, Washington State Prescription Services. People who live outside the United States, as I said earlier, are not eligible for Part D coverage. The formulary, which is the drug list, the covered drug list, will be available through the HCA website and MODA's website starting in October. And the pharmacy network list, just as it is today, is available through MODA's website and through ArrayRx starting in October. Almost all of the pharmacies that are currently available would be available under the Part D coverage. There may be additional pharmacies available under the Part D coverage, so it's important to check that your pharmacy will accept the plan. For Kaiser Northwest, again, the Senior Advantage plan is now Senior Advantage with Part D. There are lower monthly premiums, and there's no deductible for prescription drugs. These are the tiers of drugs for KP Northwest, and I have a chart a little later on that will compare all the copays across all the plans. And when I said that it's up to the plan how they categorize the drugs, it's these tiers and how they do this, and that's done in coordination with the CMS. CMS has to approve the formulary. So this is KP Northwest specifics. Mail order drugs. This is through Kaiser Pharmacies. You can get a 90-day supply for 2 times the copay of a 30-day supply. So the copays shown are for a 30-day supply. You multiply that by 2, that's what you would pay for a 90-day supply. It's like getting 30 days without a copay. The exception is specialty drugs, which are limited to a 30-day supply, and that is true across all plans. The true out-of-pocket maximum, this is a benefit that applies to all Part D plans, whether they are employer group plans or individual plans, whether they are embedded in another plan like a MAPD or like the embedded plan in UMP, or whether they're standalone plans. The Inflation Reduction Act created a $2,000 a year maximum. So nobody on Medicare would pay more than $2,000 in a year for their prescription drugs. It's important to note that this applies only to prescription drugs and only to the drugs on the major formulary. There is a low income subsidy that is available for prescription drug help, and that's for people with low income who are notified by Social Security about that. And the formulary for KP Northwest will be posted in October. KP Northwest, ironically, is only available in Southwest Washington. So it's only Clark and Cowlitz counties and some counties in Oregon. KP Washington, original Medicare will no longer be offered in the PEBB portfolio in 2025. KP Washington Medicare Advantage will become KPWA Medicare Advantage with Part D. It will have lower monthly premiums, and there's no deductible for prescription drugs. As I said, there's in the KP plans a service area limitation, so they're only available in certain places. This is the map of the counties where KP Medicare Advantage, KP Washington Medicare Advantage with Part D will be available. And again, you will have these slides so that you'll be able to refer to them and see the details on the map. The tiers are basically the same for KPWA as they are for KP Northwest. There is a difference in copay supplies, so it's important to look at them. And again, I have a chart that's going to compare all the plans, so we'll go through that. And all the same things apply for KP Washington in terms of mail order through KP pharmacies. All the Kaiser Permanente pharmacies are in the MAPD network. And there are a couple of pharmacies that people are using now that they might have to change. And again, the details will be listed on the KP website. Now I'm going to talk about benefit changes generally in the Medicare portfolio. So KP Northwest is increasing the hearing aid benefit to $3,000 per ear every 36 months. And the vision hardware benefit, so that's either contact lenses or eyeglasses and lenses, is increasing from $150 to $200 every 24 months. KP Washington also increased their hearing aid benefit to $3,000 per ear every 36 months. United Healthcare has also increased their hearing aid benefit to $3,000 per ear. This is a big difference for United because it used to be a combined limit. So it's now $3,000 per ear. And it's still every 3 years, and it is still restricted to the United Hearing Network. That's their network of providers. So it does not include, for example, hearing aids at Costco. You cannot use the benefit outside of the United Hearing Network, but it's a very comprehensive network with comparable instruments available. This slide is probably the most important slide or of greatest interest to everybody. This is the 2025 Medicare single subscriber monthly premiums. So on the third line from the bottom, you will note that UMP Classic Medicare with Part D has gone from $534 a month down to $419. So it's a saving of over $100 per month, and that's directly relatable to using the Part D prescription drug coverage. The premiums shown include or after the Medicare explicit subsidy of $183 or 50% of the premium, whichever is less, has been applied. So these premiums are what you actually pay. The subsidy has been applied, and these premiums include a $5.71 administrative fee. I often get asked, well, what do I pay if it's me and my spouse? So I have done the math for you, and like a good teacher, I'm showing you my work. So it's 2 times the single subscriber amount less $5.71. And the reason is this would be a subscriber and spouse on one account, and we applied the administrative fee only once per account. The assumption here is that both spouses or both people are on Medicare A and Medicare Part B. And it's not just eligible, but they're actually enrolled in Medicare Part A and Medicare Part B. Again, you will have these slides so that you'll be able to look at this. This is just a glance, if you will, a very summary, high-level view comparing the benefits. So just to go through a few things, except for the Kaiser plans, all of the other plans are nationwide, which means if you're traveling out of state, you can see a provider. If you live outside of Washington State, you can still be on PEBB insurance and have coverage even though you live outside the state of Washington. The Kaiser plans, again, are regional plans. They have a limited service area. There is a medical deductible for UMP Classic Medicare. And again, for Plan G, the deductible would be the Part B deductible. You don't have a further deductible. The Medicare Advantage plans do not include a medical deductible. There is a pharmacy deductible for UMP. There's also a pharmacy deductible for the United plans. There is no pharmacy deductible for the Kaiser plans. The Medicare supplement plan, although it says yes for the pharmacy deductible, I'm sorry, it says not applicable. That's because there's no drug coverage. You have to obtain a standalone Part D plan, and it's up to the plan that you pick. There are different providers. This is all outside of PEBB, so we don't have specifics on whether or not there would be a deductible. Hearing aids, glasses, contacts, massage therapy. Again, those are covered by all the plans except for Plan G, and the reason is those things are not under basic Medicare. And so again, a Medicare supplement plan covers just the basic medical. Gym membership is not available under UMP Classic Medicare. It is under the Medicare Advantage plans, and it's not available under Premier Plan F or G, but there is a Premier discount available. And then obviously drug coverage is yes for everybody except for Plan G again, because you have to get a separate Part D plan to get drug coverage. This chart is a way to compare some very common medical benefits. Now, this wouldn't have all of the specific details. Like if you had a hospital admission, you might have different providers listed under that hospital admission. This wouldn't list all of that, but these are the general copays. For UMP Classic Medicare with Part D, you still have coinsurance, which is a percentage of the cost of the service. For naturopathy, there are some limitations that you need to look at the certificate of coverage to determine. All the other plans have copays, which is actually a dollar amount. So just to go through this, for hospital coverage under UMP Classic, you would pay $200 a day up to $600 per admittance. So if you were in the hospital for 4 days, you would pay only the $600. Kaiser Northwest has just a $500 per admission copay for hospital. Kaiser Washington has $200 per day up to $1,000 per admission. So again, if you stayed 6 days, you would pay $1,000. If you stayed 3 days, you would pay $600. There's a limitation in naturopathy in Kaiser Washington to 3 visits per year. United PEBB Balance has a $500 copay per admission for hospital stay. And you have copays for your primary care specialist, outpatient surgery, and naturopathy. For PEBB Complete, there are $0 copays, including hospital admission. You don't pay a copay. But for naturopathy in PEBB Complete, you would pay $30 per visit. And then Premier Plan G is $0 copays, and naturopathy is not applicable because, again, naturopathy is not a Medicare covered service. I want to talk a little bit about the drug benefits. So as we stated, there is a deductible for Medicare, UMP Classic Medicare Part D, and for the United plans. And I'm going to go through a little bit of a detailed explanation of how that works. The deductibles in all of these plans do not pertain to generic drugs. So if you're getting generic drugs, you don't have to meet the deductible. And as you can see, the maximum out of pocket that you would spend is $2,000 for every single plan. Again, this is the result of the Inflation Reduction Act. And the way that the maximum out of pocket is calculated is based on copays, and you may actually reach that. It's based on the standard benefit of Part D, which has higher copays than we have negotiated in our group Part D plans. So you may actually reach the $2,000 maximum prior to actually spending $2,000 out of pocket. Once you reach that $2,000 maximum, even if you haven't actually spent all of that, but the plan has calculated that, then your copays go to $0 for the rest of the year. Again, the maximum out of pocket is calculated just on prescription drugs and not over the counter or bonus drugs. Here are the specific tiers, and as I mentioned, it's up to the carrier and CMS to determine the I can't say it, the different categories that the drugs are in, and those categories relate to tiers. So you can see that most of the plans have 5 tiers. The United plans have only 4 tiers. The reason is that United has combined the preferred generic and generic tiers into one giant tier called Tier 1. So the deductible does not apply to Tier 1 in any case. And for the plans that have Tier 2, it does not apply against those as well. So let's talk about how the deductible and copays work. Let's say that your first prescription is for a preferred brand drug. And let's say the true cost of that is $36. It's very unlikely, but you would pay the true cost, which is $36, and you would keep paying that until you reach the $100. So it would take you 3 fills of that drug. Once your deductible is met, you would pay either the true cost or the tier copay. So let's use a slightly different example. Let's say that you have a preferred brand drug. Let's use Eliquis. Eliquis usually costs about $250. So the first fill in Eliquis would be for UMP Classic Medicare or the Kaiser plans. It's Tier 3. The first fill, you would pay $100 towards that true cost. That's what you would pay, is $100. Your next fill, since you've already met your deductible, your next fill would be $40. For the United plans, the benefit is the same in PEB Complete or PEB Balance. Same example, $250, you would pay $100 the first fill, the second fill would be $45. That's your copay for Tier 2. So these copays really are after the deductible is met. So after you've paid your $100, this is what you would pay for subsequent refills. These are the copays for 30-day supply. Specialty drugs are always limited to a 30-day supply. But mail order 90-day supply for all the plans is 2 times a 30-day supply for all the tiers. So even if it were a generic and the copay was $10, you could get a 90-day supply for $20. It's like getting a 30-day supply without a copay. Preferred insulins are specific to each plan. So whatever they've identified as their preferred insulin is $35 for a 30-day supply. All plans have that. That limitation is also part of the Inflation Reduction Act. So before I go into why choosing PEB, Lori, do we want to stop and take some questions now?
I think that's an excellent idea. So I'm going to go back to the earlier questions. Just give me a second here, Ellen. Okay, the first question is, if a provider refuses to bill Medicare, what does the patient need to do to see that Medicare bill is paid?
So
Or,
if the
excuse me, to see that Medicare is billed, excuse me.
Okay, so if the provider refuses to bill Medicare, that means that they're not participating in Medicare. Providers who have signed up with Medicare must bill Medicare. It's whether they bill the plan directly or whether they bill Medicare directly. If a provider has opted out of Medicare and they're not billing Medicare, then your services would not be covered and you'd have to pay the full cost in any plan. Medicare services have to come from a Medicare provider.
Okay, thank you, Ellen. The next question is, how do we get discounts for hearing aids if we are on Plan F?
So you can contact Primera, and if you happen to go to one of the benefits fairs, Primera will have flyers available that give you information. It's also available on the Primera website. But if you call on your ID card, you should have a phone number to call for Primera, and you can call them and ask them about their discount program for hearing aids.
Okay, the next question is, I have Kaiser Permanente in Benton, which is being dropped. So if I change to Primera G, when do I get Part D? During PEB open enrollment?
So your coverage, if you change to Plan G, will begin January 1. And you should sign up in December to start a Part D plan, a standalone Part D plan, starting January 1. You don't want to, you can have a gap of up to 63 days without a penalty for Part D, but you really don't want to have a gap so that if you have any prescription drug needs, they'll be met. And Tim Smolin will be here from the Office of the Insurance Commissioner in a little bit, and Tim can speak directly to this, but you can contact SHIBA, which is the State Health Insurance Benefit Advisors, and they will give you information about how to sign up for an individual Part D plan.
So the next question, I'm not really understanding it, Sharon. So maybe you can cover that. It has to do with the maximum out-of-pocket costs for prescriptions, I believe, which is triggered in 2025. But
yes,
I
just I've never dealt with a $2,000 maximum under uniform. If it's like I take Xarelto, $75 a month, true cost is $750, which goes towards the 2,000.
So it's actually it's going to be neither of those. It's
Okay.
not the true cost. It's what the standard benefit for that drug would be is
Okay.
what's calculated as the basis. And once those standard benefit allowances have been met, that's when you would reach the $2,000 maximum. And it is not uncommon, Sharon,
Mhm.
for people not to reach the $2,000 maximum because our copays are very low. So
Right,
most
right.
people, I've had only a few people on each plan actually reach it.
My husband takes 5 prescriptions. We pay about $16 a year for all of his prescriptions, you know, so okay, thank you. That clarifies. I appreciate it.
You're welcome.
So the next question, I think, it's from Christine, and I believe that she's seeking clarity about the explicit subsidy. And so I would give a very simplified answer to this, but she's asking about the 183. And so maybe you can explain where that comes from and how that lowers the premium cost for the Medicare eligible retirees.
Sure. So that is money that was set aside by the legislature. It's determined by the legislature and it's approved by the PEB board. And it's a way of giving extra benefit, if you will, to PEB retirees on Medicare. So when the plans submit their bids to HCA, we take that bid amount, we apply the subsidy to it. So the actual cost is higher than what you pay in premiums because the state has funded up to $183 or 50% of the premium bid, whichever is less. And you get the benefit of that. It's meant to lower the premiums, and it was an act of the legislature.
Thanks, Ellen. Okay. Okay, so the question is, does the Kaiser Washington Medicare Advantage plan's $2,000 maximum out of pocket only include the drug costs? And if so, is there another maximum out of pocket for medical services?
So there I'm not certain about the medical out-of-pocket limit.
Doesn't it vary by plan?
It does vary by plan, and
Yeah.
I'm not exactly sure what the Kaiser plans are, but let me talk a little bit about the Kaiser pharmacy benefit. So Kaiser currently does not have an upper limit on how much you pay for drugs. So if you had very expensive prescriptions under Kaiser, you could well spend more than $2,000 a year on the prescription drugs. And it's based on your copays, not the actual cost of the drug. As I explained to Sharon, it's not just the copay that's listed, because the way that the plan determines how you reach that $2,000 is based on the standard benefit for Part D. And those copays are generally higher than any copays that we have. So you might reach the copay limit well before you spend $2,000. You might never reach it if you don't spend a lot of money on copays. But it is a new benefit really for Kaiser members, because they never had a cap on their prescription drug costs, and now they do.
Perfect. So Aruna, you may need to clarify this. The first part of the question has to do with the $2,000 out of pocket. I think that, Ellen's clarified that for on the drug side, and she also provided a response on the medical expense side. But did you have, is your comment or question something different than that?
Yeah, I just wanted to know, does the $2,000 out-of-pocket limit, does it include premium as well as the drug deductible?
No, it does
Mm.
not include premiums. And if you are on Plan G, you'd be on an individual Part D plan.
Uh-huh.
There is a $2,000 maximum on the individual Part D plan. Again, it will operate the same way. Whoever the carrier is will calculate the standard benefit and the copays on your particular plan, and then figure out when you reach the $2,000.
Thank you.
Second part.
And Aruna also had a comment about the gym memberships, and
Yeah.
they are not always available at all facilities, and that is correct. And that's outside of the scope of, that's just a benefit that's offered through the Medicare Advantage plans.
And through Primera discounts, and it's up to the carriers and the different facilities what they negotiate. That's not part of our negotiations with the plans.
Thank you. Okay. Under UMP Classic Medicare with Plan D, does a retiree have the option to choose a preferred insulin?
No, so the plan has determined what the preferred insulin would be, and I know that there's a difference on UMP, and now I can't remember which. It's either Basaglar or Lantus. I think it is now Lantus that is preferred. So that's the preferred brand. Other brands are available. You would pay a higher copay.
Okay. This is kind of a specific one, but we've got a member on today that is covered under the UMP Classic Medicare with the new
Lori,
Part
I'm having
D.
trouble hearing you. I'm sorry.
You are?
Yeah, that's
Okay.
better.
It's my microphone, sorry. Okay. A member is covered under the UMP Classic Medicare with Part D, but it has dual coverage on the Railroad Retirement Medicare. And the question is, will the transfer to Part D also occur with the Railroad Retirement Medicare?
That is a great question. I don't know the answer offhand. I'm going to suggest if that person would contact me, I'll give you an email contact at the end. I can double check. I'm sure that there's coordination. I'm just not sure how it exactly would work. So I need to talk to Moda, which is the administrator of the Part D plan. So we'll make sure that we get an answer to you.
Okay, and then there's some comments in chat. Okay, these are mostly comments in chat. Okay, if you have UHC complete, does moving to Part D mean that you won't be receiving prescriptions from the company Optum anymore?
So UHC already includes Part D. It always included Part D, and it is exactly the same. The change to UMP has nothing to do with any other plan. It only affects UMP Classic Medicare. So the UHC pharmacy is still through Optum.
So another question, will there be a list of the PEB Part D plans? And Ellen's PowerPoint is here. You can also get that information on the website. I know that she normally has, she puts that in the back resources, and we'll have a website as well. Alyssa, would you mind popping the PDF again in chat for people? It was the first item in chat.
Yeah, one sec.
Okay.
So I just want to make it clear to people, there is no standalone Part D plan in PEB. You cannot get just a Part D plan. You cannot get a Part D plan to mix with any other plan in PEB. In PEB, you have the choice of either Medicare Advantage with Part D, and there's a couple of different carriers, or UMP Classic Medicare with Part D. Those are the only choices.
Okay. So we've got a member on who will be turning 65 and wonders, do I sign up for regular Medicare A and B first? Then do I sign up for PEB? What is the procedure? And I just want to mention too that Tim Smolin and Alyssa Brady, who's on, Alyssa's our podcast host. And so there'll be a special podcast about open enrollment for Medicare for those who are joining Medicare for the first time. So that'll be available soon on the RPEC website, and you will need to register on our website to get access to that podcast and information. Ellen, did you want to tackle that briefly, and then maybe Tim can when he gets on?
Sure. So you can sign up with Medicare up to 2 months before your birthday month, the month of your birthday, or up to 3 months after your birthday. So a total of 7 months. However, in order to enroll in PEB Medicare coverage, you need to have your enrollment in Medicare first. So my suggestion is that you enroll in Medicare, get your Part A and Part B, and then you apply to PEB, and you get switched to a Medicare plan in PEB.
Okay. We've got Sharon, I'm happy to answer your, I don't think that Ellen will have an answer for you on this because I think it's probably something you might need to address with a physician. But the question is, would insulin be used to step as treat meds as, excuse me, would insulin would be treated as step meds?
No, so
Or-
insulin, step therapy is not required for insulins. It may depend on the brand or the formulation if you're switching to a different long-term formulation. But generally speaking, no, step therapy would not be required for insulin.
Another question, if a person has opted out of PEB at retirement, can they enroll in PEB later?
So the only way to do that is to defer your enrollment in PEB. Deferring is an action that you have to take, and it means that you are putting off for later selecting a plan in PEB. You cannot opt out of PEB and then come back to PEB. You can defer your coverage as long as you meet all the eligibility requirements, and then come back to PEB after deferral.
Okay. We get this question every year, but I'll give it to you, Ellen, so you can answer it. We've got a question about whether HCA has a sense of the retiree satisfaction regarding the various plans, difficulties in dealing with the plans, getting information on
Yeah, overall,
approval and denial rates.
yeah, overall, I know that people are not happy with this answer, but overall, we do not hear a lot of complaints. Each plan has people who don't like it. Each plan has people who love it. It's really a personal experience, and we're not hearing about denials out of proportion from one plan to any other plan.
Aruna, I don't understand your question. So could you state it for Ellen?
Ellen, you had mentioned that if a person is on Plan F, and then if they get out of the Medigap plan, and if they want to re-enter, they will get only availability of Plan G. I just wanted to know why a person would get off and then try to get onto it.
So, Aruna, you may not have as much experience with this as people in the Washington Education Association, but we have a lot of retirees who end up doing substitute teaching. And if they spend enough hours that they qualify for employer-sponsored medical insurance, they have to take that over their retiree insurance. And so they would lose Plan F, but they could come back to Plan G.
Okay, thank you so much.
Morning, Ellen.
So I think that the next,
Tim.
hi, Tim.
Hi,
The
Lori.
next question may be for Tim, because it relates to the individual Part D plans, which, as Ellen said, aren't available through PEB. So you get a sip of coffee, Tim. So before we start pounding you with questions, that's going to
No.
be your first softball question.
I'm so happy to be here. I want to help Ellen. With
Oh, we should
question about-
introduce you. I just assume everybody knows
Gosh, I know
Tim.
I'm like a celebrity. I'm so happy to be with you all. I'm Tim Smolin. I'm the program manager for the SHIBA program, and SHIBA is a free, confidential, unbiased public service of the Office of Insurance Commissioner. We have a state Office of Insurance Commissioner. Aruna is one of our volunteers out in Spokane. Nancy Healy and I used to be colleagues here at the OAC. Nancy, nice to see you. Susan and Robin, I saw them in Pasco this week. They hosted me, so lovely to see you. I'm super sad Ellen is retiring, but our colleague Laura Ryan is going to succeed her. She's been working with us here at the OAC for a couple of years, so we're very excited about her transition. And I wanted to help Ellen with the question about feedback about the PEB plans. I think that in general, there's a lot of skepticism or animus towards Medicare Advantage plans and managed care plans in general. And I think it's largely well-deserved because there is just a host of problems with referrals and networks and prior authorizations and billing challenges. And I guess I would just counsel that people should understand that the plans that the managed care plans in the HCA PEB portfolio, so I'm talking about the 2 United Healthcare plans, the Kaiser plans, those are really very different, and people are not going to have those same bad experiences. And the reason why is because, number one, they're managed by HCA and PEB and Ellen, and she's too modest to take credit. But the oversight that the HCA offers really makes a difference in terms of the performance of those plans, in terms of basic things like customer service, and then all the way out to access. And it is a different benefit design. So it's more permissive. It has a broader network. It has a better pharmacy benefit. And there's fewer restrictions, right? There's fewer managed care aspects of those managed care plans in the PEB portfolio than there is in the commercial market. So I would just caution people, and I'm not meaning to put my finger on the scale in terms of switching behavior, but if people are in UMP and thinking, I might try United Healthcare, but I've heard so many horror stories, I would say that's not the experience of people in PEB. That's the experience of people in the commercial market. Can I say that, Ellen? Ellen, it's her agency, so she has to be a little bit more circumspect, but that's the truth.
Thanks, Tim.
You're welcome.
So actually, it's a great segue if I can go on with the
Ellen,
slides, Lori.
can we grab one more question?
Sure.
So we have a member that's currently in UMP Classic Medicare and is considering a change to Primera. The question is, does this person need to, if that change occurs, do they need to choose a Part D plan?
Yes, when they go to Plan G, they would need to choose a Part D plan, and they'll talk to Tim about that. But Tim's comments were a great segue to my next slide, which is why choose PEB? And really, it's important to think of PEB like a giant union. We're the employer group, and that means that we have the ability to negotiate with the carriers for all those things that Tim was talking about. So, we have performance guarantees. We have requirements that we can impose on the carriers because we are this large market basket and we can drive the negotiations. Part D in PEB, and again, there's no standalone Part D plans, but the Part D plans that are embedded in all the other PEB plans generally are bit richer and have better benefits than what's available on the commercial market. They may have lower copays, they may cover more drugs, they may include things like some over-the-counter products that wouldn't normally be covered by a Part D plan. And then perhaps one of the most important things is that PEB can intervene when escalation is needed. So for those things, those horror stories that you hear about people on Medicare Advantage plans where things are denied and they can't do anything about it, PEB stands between the member and the plans, and we can escalate situations and make sure that needs are addressed in an appropriate manner. Another benefit that's very important, and this is especially important going forward, you can change your Medicare plan every year during open enrollment. So if you were on a plan and wanted to try a Medigap plan, for example, or a Medicare supplement plan, those are the same thing. So you want to try Plan G, you can do that, and then next year come back to UMP, let's say. The only restriction that you need to know about is you can only have one Part D plan at a time. So if you have Part D on the commercial market, and then you want to come back to PEB and pick up a plan that includes Part D, you will need to disenroll, drop your commercial Part D plan. And that's not difficult. That happens all the time. You just call the plan and say, I want to disenroll from it. If you come back to, for example, UMP, I know that there's been a lot of misinformation. People think that they can't come back if they go on a Medicare Advantage plan. Again, because you're part of a group, you can come back and you can go in or out of a Medicare Advantage plan, in or out of a Medicare supplement plan, in or out of UMP. There would be no medical exam required. There's no special underwriting required for change. And there can be no added fees for a pre-existing health condition. So you would pay the same premium anybody else pays. And then PEB Medicare plans, and we've said this a number of times, are richer than generally anything on the commercial market. It's important when looking at expenses, it's not just the premium. There are a lot of zero premium plans on the individual market. They have very high copays or very high out-of-pocket limits. And that's generally much, much lower if you look at the PEB plans. Now I'd like to switch and talk a little bit about non-Medicare retiree options. So there are people who are lucky enough to retire before they turn 65, and those are non-Medicare retirees. All retirees are in PEB, regardless of Medicare eligibility. But non-Medicare retirees have plan options the same as what would be available to employees. So the Primera plans that are currently available in SEB, for example, are not part of the PEB portfolio. What's new for 2025 is vision has been carved out of the medical plans. So today, everybody, active employees, non-Medicare retirees, their vision is included in their medical plan. Starting in 2025, employees and non-Medicare retirees will have vision carved out, and they will have standalone plans. It's optional for retirees, even non-Medicare retirees, but you have to be in a PEB retiree plan to get vision as a standalone. So you cannot have vision by itself. You cannot have dental by itself, but you can be in a PEB retiree medical plan and have vision and or dental. So you could have just vision, just dental, or both of them, as long as you have your PEB Medicare retiree plan, medical plan. So as I said, and again, this is non-Medicare. In Medicare, vision is included, standard vision with routine vision benefit of having an eye doctor exam, for if you need eyeglasses, that's part of your medical insurance. Routine vision is now being carved out for active employees and non-Medicare retirees. So it's routine vision coverage, it's eye exams, and it's hardware, lenses and frames or contact lenses. The plans are the same carriers as those available in SEB, Davis Vision, iMed, MetLife Vision, but these plans are not available for Medicare retirees. Again, your vision coverage is included in your medical plan. It's important to note that Plan G has medical coverage for eye diseases, but does not cover routine eye exams. So if you're in Plan G, you might want to get standalone vision coverage. You cannot get it from PEB, but you can get it from the open market. Vision coverage for eye diseases for employees, non-Medicare retirees, all retirees, Medicare retirees, everybody. Vision coverage for eye disease or, glaucoma or cataracts, all of that is covered under your medical insurance. Standalone vision is only what we call routine vision care. It's an eye exam and eyeglasses or lenses, contact lenses. Beginning January 2025, the hardware allowance for all plans will be $200. The hardware benefit will reset in odd years, so 2025, 2027, 2029. This is sort of for anybody who's got somebody in SEB as well. This is an added benefit because if they're in SEB and they currently have their vision and have not used their benefit yet, they could quickly take advantage of their benefit in 2024 and then get a reset January 1 in 2025. The core benefits, the eye exam, is the same across all three plans, but then the specific benefits, what kinds of lens enhancements, tinting, progressive lenses, things like that are specific to the plans, and that will be available on the HCA website. Why does non-Medicare coverage cost more? Well, this relates to the explicit subsidy that we talked about before. So as a retiree, you no longer have access to the employer contribution. As an employee, your employer currently pays 85%. So that's no longer available if you're a non-Medicare retiree. And you don't have access to the Medicare explicit subsidy yet because you're not Medicare eligible. So those two things are taken away. And then tobacco use and spousal surcharges would still apply. They do not apply to Medicare accounts. So that could be reasons that drive the premiums up. The alternative is you can defer PEB coverage. Again, deferral means postponing your PEB coverage because you have other acceptable coverage. And you must meet all of the eligibility requirements. So a question to ask is, is there another employer plan available? That would be the best, least cost option available. So if you had a spouse who's employed, whether by the state or somebody else, that might be the way to go. And then COBRA is another alternative. Remember, you don't just want to retire and not tell PEB because you would lose your ability to come back to PEB. So you want to defer your coverage if that's what you are planning. These are the non-Medicare single subscriber premiums. As you can see, they're very high. And as you can see, they're different plans than the Medicare plans. We have only 2 providers, Kaiser's, actually 3 because it's Kaiser Northwest and Kaiser Washington, and then UMP. And there are various plans under each of those. And then of importance to this group is we have what are called split accounts. Split accounts are where one person is on Medicare and the other is not. And the rate is the combined rate of Medicare and non-Medicare coverage. So again, it's pretty expensive. So here are the split accounts with the Medicare plan and then the non-Medicare plan that matches it. And this is the premium for the subscriber and spouse. So this would be 2 subscribers. One is Medicare eligible. It could be the subscriber or the spouse. One is eligible for Medicare. One is not eligible for Medicare. This is the combined premium. And you can see that for UMP Classic Medicare, United PEB Balance, and United PEB Complete, the companion non-Medicare plan is UMP Classic. And for the Kaiser plans, there are specific plans that go with the Medicare plans. These are the premiums for dental. Remember, you have to be on a PEB retiree medical plan in order to get PEB dental. It's optional if you want it. These are the single subscriber premiums. If you had 2 people covered, you multiply it by 2. Delta Care is a managed care plan. That means the copays are fixed. There's no limit, and that's what you would pay. You have to see providers in their network. Willamette is also a managed care plan, operates the same way. And the Uniform Dental Plan is a preferred provider organization PPO plan. Dental insurance works differently than medical insurance. In dental insurance, the maximum is not your out-of-pocket. The maximum is what the plan would pay. Only the Uniform Dental Plan has a maximum, and it's $1,750 per year per person. If you use a preferred provider, the plan pays the most towards the bill. If you use a premier provider, you can do so, but the plan would pay a little bit less. And again, vision for non-Medicare retirees can be added. Here are the premiums. And again, the Medicare plan itself includes vision coverage. So if you're both on Medicare, you would not be able to choose a standalone vision plan. And now I'm going to turn to open enrollment, Lori, unless there are questions related to any of the non-Medicare stuff.
Let me take a look here. You got some nice kudos in here. Okay, so I think I don't know if there is an answer to this question. It's a follow-up to Aruna. Will retirees be able to take advantage of PEB's Part D plan on Plan G in the future?
So right
That's a
now,
federal.
there's no procurement scheduled for a standalone Part D plan in the PEB portfolio. That's a process that would take at least 2 years to put in place. We'd have to do a procurement, find a carrier, and then go to contract. So, you know, it's something to keep discussing with the PEB board if people are interested, but there's no plans right now.
So there was a question, there was really a comment in chat, not a question, that the reason that UMP Classic has high rates is that only the sickest retirees keep the plan. And the other comment is, I'm not sure I'm not at all sure that people like me are going to save money. So that's more of a, I don't know, a statement rather than a question. It probably
Well,
depends on the individual circumstance unless you want to
exactly.
address that.
So it's not necessarily true that UMP has more higher utilization cases, which be the sicker. That's not a term that we use. So it's not necessarily true that there's more cases of higher utilization in UMP than any other plan. And then in terms of saving money, so everybody on UMP would save money off the bat because the premium's $100 lower than it was. On top of that, your copays are generally less expensive than they were. So yes, it is true that somebody could end up paying more, but I think overall, over the course of a year, virtually everybody in UMP is going to save some money. May not be a lot of money, but everybody's going to save some money.
Ellen, I think this question is going to be for Tim. Tim, can you provide a range for what the cost is for the Part D plans for the retirees who have chosen Primera?
Yes and no. So yes, in the way that there is a range and we have a list of what all the currently available, we call these standalone Part D plans because you have a Medicare supplement plan and then you buy a Medicare Part D plan to take care of the prescription benefit. And so standalone to us means different than the ones that are integrated into a Medicare Advantage plan. So we have a list of the current offering of all the plans, all the rates, that we publish. You can also use Medicare. Medicare.gov has an excellent tool called the Plan Finder tool. And the yes and no part of it is because those rates are only for 2024. They haven't loaded the 2025 rates yet, but they'll be out there very soon. So in general, everybody in Medicare right now is getting these two documents, and apologies for jargon, but one is called the Annual Notice of Changes. So by the end of September, everyone in Medicare is going to get a notice of, for your current plan, what's different for next year. So ahead of the Medicare open enrollment period, you get kind of a summary of all of the changes. And you're also going to get the annual evidence of coverage notice, which is all the details behind the headlines, right? So when the plan publicly says, we have dental benefit, then you go to the evidence of coverage and it says, use these dentists to pay for these procedures with this prior authorization, right? So we don't have the 2025 plan year rates yet, but it will be a range. And in general, it's a big range. I mean, we're going to see plans that cost $5 a month and $105 a month. And it's all about what is on the formulary. The other thing that I would say about this, and Ellen, I apologize, I came in late to your program again. A really significant change for the Medicare population in general, and for folks that want to consider Primera and Plan G, is that Primera and Part D, all of the Medicare plans starting in January 2025, whether they're integrated Part D plans or standalone Part D plans, will have an annual $2,000 maximum out-of-pocket benefit. So what you're going to see is a lot of redesign for all of those Part D plans in the commercial market. So yes, there is a range. Yes, there will still be a range, but we would encourage, and I know it's really hard to say, like, sit on your hands for 30 days, but wait and see the first week of October when all the new plan data is revealed on the Medicare website. The last thing I would say is that all the UMP plans are already there. So whether you're buying, you know, a UMP or United Healthcare or Kaiser, they're already at that $2,000 maximum out-of-pocket limit. So they're already ahead of where the commercial market is going next year. So I think that's a good example of when I say that these are better plans than the commercial market. That's like a really salient example.
Just a slight
Thanks.
correction, because the Kaiser plans currently don't have an upper limit on prescriptions, but they're going to have the $2,000.
Thank you. Yes.
So Lori, I
Um,
think I'm going to move into the open enrollment.
Can we do one more? I
Yep.
think I've grabbed them all. This is, so it sounds like a member would like some clarification. It says the combination of UMP and PEB balance costs more than UMP PEB complete. So I guess clarification on that.
So the split account. I have to double check. That may be an error on my part in that I have different ways of some things are alphabetical and balance comes first and some things are not. So I have to double check the premium list. And if that is not true, then I will send out a correction through Lori.
Thanks, Ellen. I think we
Thank you
got
for
all
that
the
clarification.
questions. I think we got them all. Okay.
Okay, great. You know, there's at least one error in every set of slides. So if you caught it, that's great. And I appreciate it. And I apologize. Okay, open enrollment. So first off, it's important to remember that open enrollment for PEB is what controls. It is not the same as the Medicare open enrollment period. You must meet the PEB open enrollment dates. Open enrollment will start the last Monday in October and will end the Monday before Thanksgiving. This was a change that was made to ensure that people could get the assistance that they needed before the Thanksgiving holiday, and that they would not have any delays for mailing in forms if they were doing that based on that holiday. So for this year, the dates are October 28th to November 25th. And if you're using a paper form, it must be received by HCA by November 25th, not postmarked. We have to receive it. However, I want to point out that if you are currently in either of the Kaiser plans and are happy with them and want to stay, you do not need to do anything. That's the Kaiser Medicare Advantage plans. Or if you're in UMP Classic Medicare and you're happy and want to stay there, you do not need to do anything to take advantage of the Part D. We will automatically roll over your enrollment to the Part D plan. So you do not have to take any action in open enrollment. Benefits fairs, the schedule of cities and dates will be in the October newsletter. And they will also be on the HCA website as of October 4th. The benefits fairs are open to all, SEB, PEB, active, retirees, non-Medicare, Medicare, everybody can come whenever. They generally run from 11 a.m. to 6, or it might be 10 a.m. to 6 p.m. There will be presentations from the retiree plans. Primera will be making a presentation. MOTA will be making a presentation on the UMP Part D, and the United Healthcare will be making a presentation. And then the Kaiser plans in the areas where they have Medicare Advantage plans available, they will be making presentations as well. The virtual benefits fair is something that's hosted on the HCA website. It is a way to find materials about each plan that's available. And that information is available 24/7. You can go to the website, and again, that will be updated October 4th. So I've given you the general HCA website, hca.wa.gov. That's where you'll find the virtual benefits fair. It's where you'll find the retiree open enrollment page. We have a special landing page just for retirees that walks you through all the information that's available. You'll find information on the premiums that will all be posted as of October 4th. PEBB customer service is available Monday through Friday from 8 a.m. to 4:30 p.m. Lobby services, which is where you can come to the HCA headquarters on Cherry Street and talk to a customer service representative and get some information or help on filling out forms or making decisions. That's available from 8 a.m. to 4 p.m. on a drop-in basis. And then Sheba has their phone number, and they are available Monday through Friday from 8 a.m. to 5 p.m. And with that, if you have questions, as I mentioned before, and the person who was going to send me some specific information about the railroad in retirement, please use this email, HCA PEBB Medicare, all one word, at hca.wa.gov. And with that, I'm going to turn it over to Tim. Unless there are more questions, Lori.
Yeah,
No
there
problem.
are some. Just give me a second to work through this. Is there a flow chart available for the PEBB retirees who are losing Kaiser with regard to next steps before open enrollment?
Yes, they will receive a letter with what they need to do and what plans are available for them.
Okay, and that will include details about the medical coverage, pharmacy, dental, and vision?
It will include information about the plans that are available. Then they have to go look at the plans that are available.
Got it. So the next one is Tim. So Tim had asked Ellen if you could address how people take action at medicare.gov after the HCA PEBB open enrollment period.
Yep. So Ellen, I love working with Ellen. She's great. And Ellen, I think a thing that you and I have to talk about for a quick second with our friends on the phone, because you identified that the PEBB open enrollment period, right? Because it's a group, the group sets the rules about making changes, right? And so because it's not coincidental with the Medicare open enrollment period, there's going to be this space, say, around Thanksgiving, right? Because the Medicare open enrollment period is October 15, December 7. So this is not an easy thing to message, Lori, but the concern that I have is that that someone is going to kind of misconnect the dots, right? So what they're going to understand is if I want to have Premera Plan G, I need to go buy a Medicare Part D plan. And the way to do that is to go to the Medicare.gov website and pick one because, right, HCA is not negotiating those plans. They're commercial market plans. And they're going to do that after after the HCA enrollment period, but ahead of the Medicare deadline, right? And that'll work perfect if they're in Premera. But if they're in another HCA plan and they do that, then they're going to have a problem.
So let me parse that out just a little bit.
Yep, thank
So
you.
yes, Plan G, you need to get a standalone Part D plan that you get from the commercial market. And the reason that that would work perfectly is because you would have met the HCA PEBB open enrollment period, said that you were going to choose Plan G that takes care of PEBB. You have time after that whether, as long as you meet the Medicare enrollment period, which ends December 10th, I believe, 7th. So up until December 7th, you have time to pick your Medicare Part D plan off the commercial market. Those two things are separate, and those can have separate timeframes. But you have to meet your PEB enrollment period to select Plan G. Okay, that's situation one. Situation two is something way more complicated. I'm going to try to simplify it, but it's something Tim said. If you choose any other PEB plan, so any other PEB plan in open enrollment will automatically include Part D, right? Plan G does not, but any other PEB Medicare plan, when you choose it in open enrollment, it's going to include a Part D plan. If you then go to the open market and try to buy a Part D plan or enroll in a Part D plan, that CMS, the Center for Medicaid and Medicare Services, looks at the last enrollment date. So if you said on November 15th, I want PEB and I want the UMP plan that includes Part D, and then on December 5th, you go, oh no, I really want this AARP Part D plan, that's going to cancel your UMP enrollment. We will not be able to complete your enrollment because you would have a conflicting Part D plan. So the basic rule is if you choose a plan, any other plan except Plan G, if you choose that in PEB, do not go to the commercial market for anything else.
That's the answer. So the worry, I'm apparently worrying out loud, which is not a great spiritual practice, right? But someone in UMP is going to say, I don't love all these changes, but I get it. I'm getting MODA for next year. I'm going to call MODA and I'm going to say, these are the 5 drugs that I'm taking, and they're going to price it out for me and say, tier 1, 2, 3, 4, 5, $10, $20, $30, mail order, retail, and they're going to feel, okay about it, not great. And then they're going to talk to their friend. And I'm going to pick on my friend Matt here. And Matt's going to say, well, I switched to Premera and I feel pretty good about that. And I went to the Medicare Plan Finder tool and found a Part D plan that is great, covers all the 5 drugs I'm taking. And now the person is going to go hop on the Medicare website and find out, oh, as Ellen said, right, United Healthcare AARP offers a better Part D plan than MODA for me. Let me pick that one. You can't do that. Because if you do that, you will get kicked out of UMP altogether, and you'll be now exiting HCA. You have left the group, and it's not easy for Ellen and Laura and other folks at HCA to put you back again. So, right, so make your choices and feel good about it, and then just stay there. So don't use that extra time to go shopping around Medicare website. Make peace with yourself, enjoy Thanksgiving dinner, feel good about it. Like that.
Right. I mean, I think it's worth repeating. If you choose a PEB plan, do not go to the commercial market, except if you're in Plan G.
Yep.
Okay, we
I know
have
it's tricky
more
messaging,
questions.
but important.
You ready for some more questions?
Yeah, speaking for Ellen, sure.
Okay. How do you avoid the long customer service wait times on the telephone?
Well, the best thing you can do is see if you can get your answers, your questions put together prior to open enrollment, right? So information is going to be available October 4th. Open enrollment starts October 28th. That gives you 24 days to try to call in and see if you can get an answer before those long wait times. Now, understand everybody else has that same advice. So unfortunately, there's not a lot that we can do to cut down those wait times. It's always going to be a long wait during open enrollment. And then I guess the other thing I would say is if there are questions that you can put in writing, it would be great if you sent them to the HCA PEB Medicare inbox, And we can address those without you having to go through customer service and the call center. So that would be my advice.
And I'm, because I used to work at the HCA with some of my colleagues are still there. I'll say the other thing that I would counsel people is make sure that you really need HCA because you might really need the health plan. So it's a shame to wait online for 20 minutes and then get told, oh, you need to call United Healthcare, not us. And the HCA website has a nice, if you're asking about this, call these people. So Matt and other folks, I would say the waits are, super unfortunate, but don't wait and then find out you're calling the wrong place. So if you can kind of understand your question in the context of who should be answering it, I think that, Ellen, I don't know if this is still the case, but HCA gets lots of calls that HCA just redirects back to the health plans because that's where they belong.
Absolutely. And on top of that, we also get calls that really belong to DRS, Department of Retirement Systems, or Social Security. If you have questions about Medicare, do not call HCA. HCA cannot really answer them. There is a
We will
call center
happily
at
take all
Medicare.
of those. Yep.
Yep.
Okay, we have a question about the slides, so I just want to reference this again. They're in chat. And RPEC, over the last 2 years, we have developed a special landing page that includes information for our members who are in PEBB. And so we'll not only have Ellen's material, we'll have links available that will direct you right to the right pages on the HCA website. And then in addition, as mentioned earlier, Alyssa Brady, who is our host for RPEC on Air. She is doing a series of podcasts with Matt Groshong and with Tim Smolin. The podcasts will be available as well, and they will also be available in webinar format. So all of that will be on the RPEC website. This was in the member newsletter. We hope to have that page launched by early October. Okay,
And Laura, if I
let's
could
see.
just put in a plug. I have done a podcast for the Department of Retirement Systems about changes to the PEBB plans. And it has not been posted yet, but I expect that it will be shortly. So that's
Well,
available through the
great.
Department of Retirement Systems.
Yep, and we can put the link in, and we cross-promote their podcasts as well. Okay. Okay, so I think this is just a repeat of something you've already covered. So one of you can handle this. If the question is about if you apply for G, do the conditions for Plan F, are they similar to Plan G?
Yes.
And do you need to change to a Part D plan? And I believe you covered that you need to select a Part D plan.
Yes. And I think Lori I would say, and I think Ellen would support this, is that if you're currently a Primera person and you have a commercial Part D plan, again, appreciating this is effortful, but please check and make sure it's the right one for you for next year. So there's a question from Carol in the chat about, if I'm happy where I'm at, can I just not do anything? And the answer is yes. And I would just say, if you feel happy where you're at and you're a Primera person with a Part D plan, please take a minute and make sure that there's not a better one for you for next year, because they are changing quite a lot for next year, and you might find, equally good formulary pharmacy network for a lower cost. So if you're a Primera Part D plan, at least check the Part D plan.
Another question is about the Primera G and if there will be information in the in-person and virtual fairs about that opportunity.
Yeah, for sure. And again, I'll promote Ellen's work on the benefits fairs. There's 19, 4 are sponsored by the UWRA, and the other 15 are around the state. And Matt, I know it's not super convenient, but an option to skip the long time on hold is just go talk to somebody at HCA in person at a benefits fair.
And let me just repeat that Primera will be at all the benefits fairs making a presentation on Plan G specifically. And they'll have information available as well in terms of the discounts that they provide.
And they could, or we could help people understand the consequences of shifting from F to G. But in general, that should be effortless and easy for people. And for most people, it's advisable.
So I think there's a member that is currently on Plan F and wants to change to a different Part D plan. And I think what you just said, Tim, is that they can to do their homework and to make those changes during the open enrollment period.
Yes, and again, I would just say that's a thing that volunteers like Aruna are happy to do, love to do. So if you want to just kind of go as far as like you ran it and you got down to your last 3 and you want us to make sure you didn't miss something, or if you want to get us on the phone and we'll type in the list of drugs and run something and send it to you, or go as far as enrolling you, that's absolutely something the Shiva volunteers do. It's a pretty simple technology. If you're at all good at the Medicare.gov website, it's a great tool. And although you do have till December 7, Ellen and I would say do it before Thanksgiving. Hop inside the HCA deadline, not the Medicare deadline.
And Tim wanted everyone to know that in addition to the advisors like Aruna, who donate their time to give unbiased counsel to retirees that call, Tim is also made available in chat that the OIC office in Tumwater takes walk-ins. So that's another option. And then, of course, Ellen talked about the in-person and the virtual benefits fairs as well. So there's lots of different ways in addition to the call center that you can get information and specific questions answered.
And HCA has lobby services as well.
Yes, thank you.
And I know many of you
let
are
me
not here
see.
in the local Olympia Tumwater center of the universe, but we are going to be staging a series of programs with the Kitsap library system and the Timberland Regional Library System. So Grace Harbor, Pacific, Mason, Thurston, Lewis counties. So if you go to our website, you can see across September, we'll be doing just a general Medicare kind of open house, and you're welcome to come to any of those and bring these questions.
I'm scanning the chat. I think we were able to cover all of the statements and the questions from what I can see. Is there anything that maybe I've missed?
I don't think you've missed anything in the chat. Can I just make like an editorial comment for people that are thinking about changing plans?
Yes.
I had the pleasure of being hosted in Pasco this week and got to meet Robin and Susan and other folks out there. Difficult news that Kaiser won't be available in Southeast Washington. And so people there are going to have to make a change for next year. And we talked about for people that are changing plans, so whether you're this won't apply to Primera because, as Ellen said, it's pretty well like any doctor that contracts with Medicare. But if you're thinking about changing to UMP or from UMP, or if you're a Kaiser person who's shopping for a new doctor, and this is just me editorializing, right? So I'm not speaking for Ellen or the HCA here, but start now. Don't wait until open enrollment. Don't wait till the end of the year. Start choosing your next provider now. Or if you're thinking about making a change and you want to make sure that you can keep your provider, and again, I know this is a little bit tricky messaging, Lori, but like you have to identify yourself as I'm a Medicare retiree with the HCA PEBB. So don't just say, do you take United Healthcare? Because they're going to hear commercial market. And they may say no, when in fact they take PEBB, right? Because in general, they want to see PEBB members in a way that they might not want to see commercial market members. So don't just say United Healthcare or Primera or Regent, say HCA PEBB Medicare retiree, and start now. Can I say that, Ellen?
Alyssa, do you want to explain to people what they need to do you should just be able to click on the PDF and you can download it to your computer. It's in chat. Again, it will also be available on the RPEC website.
Yep. All you need to do is click on the says RPEC presentation in the chat there. And it'll download for you when you do that.
I'm not seeing any other questions. I am seeing a lot of kudos in chat to Ellen and to Tim. And so I just want to echo what members have said. We really appreciate the time you've invested, and we always value your expertise. And Tim, we're looking forward to working with you on the podcast and webinars under Alyssa's guidance. And Ellen, we're going to miss you. And we hope that you have a wonderful retirement. We know you'll be around for a bit longer, but we thank you that you made time available to give this special presentation to us. And Tim, thank you again for giving your time and being such a valued partner, both of you.
Yeah, and I just want to say, on behalf of our commissioner and the staff that I work with here, we're very grateful for all of you, whether you worked in state government or other other city, county, municipal services. Thank you for your service as a public servant. I think that at a time when sort of trust in government and confidence in government and government services is, kind of takes a battering, especially during these kind of political seasons, I want you to know that I appreciate you.
I see James raised his hand.
We had one more hand raised. James, did you have a question?
Yeah, I'm a little bit confused and I've deferred my insurance because my wife is still working for PEBS, and a note that worked good for me is I went down there and they took a copy of my insurance card through her so that it's clear to the office folks. And I'm not sure if I should, when I decide on PEBS, should I go through Sheba or should I go through PEBS? For advice.
Either one is going to work. What they can do that we can't do, James, is help you fill out all the paperwork.
Okay.
Yeah. You need them to say these forms to take this action.
Okay,
so we could help you say, like, what are the pros, cons of Primera compared to UMP compared to United Healthcare.
Okay, so maybe go to Sheba first and then finish up at PEBS with your information you got from Sheba, and go forward with that and ask them what they think.
I think so. Yeah. But the timing matters, right? What you want to do is make sure that you have the conversations with my team and Ellen's team before your wife stops work.
Right.
Yeah.
Thank you for your service. You too.
Oh, thank you.
Thank you. So I just want to make a note for people who, like James, have deferred their enrollment in PEB because they have other employer insurance available. You can also defer your Part B in Medicare so that you do not have to pay for that while you're on employer insurance. And that can be a big savings every month. So just another thing to consider.
Check one more time. Just a lot of thanks. We can read in the chat. Many thanks to you, Ellen, for all that you've done for us over the years and for today's presentation. And Tim, a big thank you for the work you're doing and the training that you provide our advisors all over the state. So thank you. An invaluable service.
Thank you for your partnership. We appreciate it.
And with that, everyone gets a few minutes back in their schedule. Thank you all for joining us, and we'll be sending out more information about when this link is available on the RPEC website. Thank you, Ellen. Thank you, Tim. Thanks, everybody. Have a great warm day.
Bye.
Bye-bye.
Bye.